Hello to all my students. I am Dr. Utsav Bansal, Ophthalmology Faculty Marrow, and this is the video of Ophthalmology NEET-PG 2023 recall. Now the word is recall, guys. So these questions are not the exact questions probably that were asked in the NEET-PG exam, right? These are the questions that we have got to know from the students who have given the exam. These are more or less the exact questions. But obviously, because so many students have given it, there are sometimes a lot of variations in the questions. So I will be trying to discuss those variations also. But keep in mind, if you think that there was some other question which was asked, please feel free to comment or, give us a feedback so that we can give the correct answer on that. Right? Now, like every time, I will start this recall session by giving you this division chart. I always tend to say that it was an equitably divided paper. But this time, alas, I am not able to say that. This time, there was disproportionately high questions from cornea, or I can say ocular surface. There were 3 questions, right? So this time, cornea was disproportionately very high. There were 3 questions asked from cornea. 2 questions were asked from lens and 1 question each from optics, glaucoma and neuro-ophthalmology. Glaucoma usually gets asked every year. Neuro-ophthalmology gets asked every year. So these are almost constants, right? The only surprise was cornea getting asked 3 questions. In total, there were 8 questions asked, out of which 5 were image-based. And yes, that is again the trend that we are seeing, that the examination is becoming more and more oriented towards asking questions based on the patient's findings. And that is basically image-based questions, or what we are afraid of, the clinical questions. Okay. Now let's start with the first question that was asked, a pretty easy and a pretty direct question. If you have read or if you have seen the videos, guys, an infant, as seen in the image, presents to the ophthalmology OPD with lacrimation and photophobia. So the 2 keywords we get here are lacrimation and photophobia and an infant. Okay. Now, what is the diagnosis? So in the question, we have got 3 keywords and then we see the image. When I see the image, obviously I will look straight at the left eye. When I look at the left eye, I see a hazy cornea. So I think that is pretty clear. If you've seen the video even once, everybody, all of you should be pretty clear that blue eyes means that it is a direct case of congenital glaucoma. So as soon as I saw this photograph, I wanted to mark congenital glaucoma. Okay. Were all the other features also supporting it? Yes. Congenital glaucoma, everybody, let's see. Congenital glaucoma, most common age of presentation is less than 3 years. So in the question, it is given infant, most common age of presentation is less than 3 years. Both of these things are matching each other. Yes. Then what is the triad of symptoms? The triad of symptoms we read as BPL, blepharospasm. Then P for photophobia and L for lacrimation. Yes, photophobia and lacrimation are already given in the question. Age is given less than 1 year. Corneal haze is given. Corneal haze is the earliest sign. Yes. We know all this, all the information that we know, that we have done in our videos. This is a screenshot from the video, direct screenshot from the video, everybody. Congenital glaucoma, blue eyes. I hope you are pretty clear about it. To revise it, everybody, let's see what are the signs of congenital glaucoma. So as we just said, cornea hazy, that is the earliest sign. Then we know the second important sign, everybody, quick revision, Harb's striae. And then the third we know as the big eye, everybody, yes or no, ophthalmos, enlarged eyeball. In enlarged eyeball, we have a blue sclera, we have axial length increase, we have corneal diameter greater than 13 mm. Yes, some of the key points that we need to remember. I hope again we remember that the treatment of choice is trabeculectomy plus trabeculotomy. Yes, so it is a dual procedure which is done. This is a quick review on congenital glaucoma, very easy topic, easy question which was asked. Now let us see if you didn't know it straight away, would we have been able to solve it even then? I think yes. Even if we didn't know the straight answer, everybody, I would have looked at the other options. It is the case of corneal haze in an infant. Can mucopolysaccharidosis cause corneal haze? Yes. But which mucopolysaccharidosis, guys? MPS 1H, that is Hurler's. Then MPS 1S, everybody. I hope you know the classification. This is Sky. And MPS 4. Okay. So these are the three common causes of mucopolysaccharidosis causing corneal clouding. But they don't present with any other features like lacrimation or photophobia or any other constellation of symptoms. Their straight sign is corneal haze. And depending on the type of MPS, which are anyways rare storage disorders, the age of presentation is also different. For example, MPS 1S, Sky disease, the age of presentation is usually after 1 year of age, not in infancy at all. Okay. So even though it is a cause of corneal clouding in infancy, it is not a very prominent cause. Congenital cataract, everybody. Congenital cataract, I hope you understand there are various types of congenital cataract. Posterior polar cataract will present with onion ring shape. Yes. Zonular cataract or lamellar cataract present with riders. So all those have typical features of their own or typical images of their own. You can never confuse that. And the last is ophthalmia neonatum. What is ophthalmia neonatum? Ophthalmia neonatum is conjunctivitis in a newborn. Conjunctivitis should present with discharge. Conjunctivitis should present with some kind of redness, not with a corneal haze. It is not keratitis, it is conjunctivitis. So even if we didn't know the straight answer, we could have used a little bit of the tactics that I say, rule out the options and then done this question very easily. Although I think all of us should have got it right. Okay, moving on guys to the second question which was asked. This was actually a question from class 12th, class 11th physics, everybody. Yes. Which of the following refractory condition is depicted in the figure? And this was the image of the figure given. Yes. If we have read optics, then we know this. If not, then I'm saying class 12th, class 11th. So what is this image? This image is something which is called as the Stern's conoid or the conoid of Stern, whichever way you want to call it. What is Stern's conoid? To understand this, even if you didn't know the answer, you just needed to look at this lens that they had given. Yes, the vertical curvature and the horizontal curvature are different. So in this surface, we see that the vertical curvature and the horizontal curvature are not equal to each other. When vertical curvature and horizontal curvature are not equal to each other, it becomes a case of what, everybody? Astigmatism. Even if you didn't know, this is known as Stern's conoid. If you had forgotten it, again, if you have presence of mind in the examination, you would always have read enough to be able to solve a question. And this is how I could have solved a question. So what is Stern's conoid? If you didn't know this, so Stern's conoid is the organization of the refraction of light rays from a toric surface. Okay. So now what is a toric surface? Toric surface is basically a surface in which the vertical curvature is not equal to horizontal curvature. When a vertical curvature and horizontal curvature are not the same, let's say this is my vertical curvature and this is my horizontal curvature. Yes. So the light rays which are refracting from the vertical curvature, let's say they will converge at this point and then they will start diverging. But the horizontal curvature, maybe these light rays will keep on diverging a long time before they are able to converge. Yes. So this will be the point. So this will be the vertical converging point. This will be the horizontal converging point. So that means because of different curvatures, there are different refractions occurring. That is basically the definition of astigmatism. Yes or no? Refractory error due to different refractory powers in both the principal axis or meridians of the eye. And the organization of those light rays is called as Stern's conoid. In Stern's conoid, the point to know or remember is this point D. In this point D, if we see, the least amount of diffusion is there. The vertical light rays have almost always converged, and even the horizontal light rays have converged. So this point D is called the circle of least confusion. That means if we are giving a toric lens to a patient, we give it of the power of the axis such that the image point D lies on the retina, which is the circle of least confusion, so that the patient is happy with the toric surface or the astigmatic lens. Okay, let's see point B. What is occurring at point B, everybody? This point. At this point, if we see at point B, the vertical light rays have already converged, but the horizontal light rays have still not converged. So there is no vertical here. This is only a horizontal line that the patient will see. Now if we see point F, everybody, this point, at this point what we see? Everybody, point F, I am marking here. At point F, we see that now the horizontal has converged, but the vertical has already started to diverge. Yes, so the patient will see only a vertical line at point F. There will be no horizontal that will be seen because the horizontal has converged and it has the point image. I hope we are clear. So Sturm's conoid is just a diagram of how the light rays will behave when they are getting refracted from a astigmatic or a toric surface, and that is what the question was. Pretty easy question, I hope. Yes, which of the following refractory condition is depicted in the figure? Myopia or hypermetropia? Myopia means both axes are the same. Yes, if we just quickly draw a diagram, myopia would mean what, everybody? If just a rough diagram we make, I know you already know. Just to clarify, guys, light rays from both the curvatures will converge in front of the retina. If it is hypermetropia, light rays will converge behind the retina. Yes, hypermetropia, myopia. There is no fundamental of any toric surface or curvature difference, everybody. Presbyopia, I hope we again already understand what is presbyopia. Presbyopia seen after 40 years of age, near vision problem. Yes, problem of accommodation. Yes, I hope we are clear about all these, everybody. Sturm's conoid. So moving on to question number 3. A 20-year-old male presents with golden brown ring over iris on examination. What next is done to diagnose the condition? Now, this seems an easy question, but as soon as you start thinking about the language, it confuses us. Golden brown ring is visible over iris on examination. As soon as I hear a golden brown ring, what comes into my mind? The first thing that comes into my mind is this word, Kayser-Fleischer's ring. Yes, but Kayser-Fleischer ring is a golden brown ring in the periphery of, yes guys, in the periphery of iris. No, na. In the periphery of cornea. Yes, we know this. If it is a golden brown ring in the periphery of the cornea, but the question has given us the language golden brown ring over iris. So what was the question asking us? Some students said, no sir, it was not iris, it was cornea. But majority of us have said that we read it clearly because this is the confusion we were having. The question had given that there is a golden brown ring visible over the iris. I say even if it was written golden brown ring over the iris, answer still was Kayser-Fleischer's ring. Why? Let's see. Let's see the image of Kayser-Fleischer ring, everybody. The image number 1 that I have marked here on the left side of your screen, this is the ring of Kayser-Fleischer. Everybody, between my 2 arrows, all of you can see in periphery a golden brown ring. Yes. Now, if I have to describe this ring, if I have to describe this image, let's say it's a 2D image, how will I describe this image? I will say that over a light colored iris, I see a golden brown ring in the periphery. Yes. Obviously, I am going to say this because my background is the iris. I am not saying that the golden brown ring is in the iris. I am just saying that the golden brown ring is seen over the iris because cornea is transparent and the background of cornea is iris. So it was just probably that language which made us spook a little. Even if we were spooked, Still, let us see how I would have approached this question, how I would have wanted my students to approach this question. So, golden brown ring over iris, Kessler Fleischer ring, let's say, due to copper deposition, obviously all of us know that, yes? In the periphery of cornea due to copper deposition, we all know this, yes? Now, what is the answer? What next is done to diagnose the condition? So, Kessler Fleischer ring is seen in which condition? Again, all of us know that Wilson's disease, it is pathognomic of Wilson's disease. Wilson's disease is diagnosed by 24-hour urinary copper excretion, or we know that the serum ceruloplasmin levels are increased. Yes, so obviously based on that, the correct answer was serum ceruloplasmin. Now, obviously there are controversies. Students who got confused, let's be gentle. Yes, they said that the answer could have been, sir, serum iron level. Why? Because serum iron level, if it increases due to something, we call it siderosis, sir. Siderosis bulbi to be exact. And in siderosis bulbi, there are iron deposits, which are basically hyperpigmented patches. Yes. So you said, sir, if it is given golden brown ring over iris, then we will assume it is a case of siderosis bulbi and the answer will be serum iron level. But then I say, have you seen a photograph of what these siderosis bulbi patches look like? If not, then let's see the image. When I see the second image on the right side of the screen, when I look at these green arrows, everybody, these are small deposits, everybody. But they are not only over the iris, they are even over the lens. And they are specifically seen in cases of intraocular foreign body. Yes, if there was some injury due to which there is an impacted iron body somewhere in the iris tissue which is leaking the hemosiderin, everybody, iron, and it is leading to these patches, everybody. There is no history given in the question of any intraocular foreign body, no history of previous trauma. Plus, when you describe this second image, you will not say golden brown ring. I don't see any golden brown ring. I can't say golden brown ring, can I? I hope we are pretty clear about this. If golden brown ring word has to be used, it will be used only for Kessler Fleischer ring. I hope I am pretty clear. There is no confusion. There is no controversy. This was not a difficult question. It just made you think. As we say clinical questions, it was basically a description of how would you have presented a case. Sir, on examination, we saw a golden brown ring present in the periphery over the iris. Yes. So that is what it was just aiming at. Obviously, it was not an image-based question. Had it been an image-based question, it would have been pretty easy for all of us. But still, I hope you have been able to get the gist of this question and why the answer is not serum iron levels. Okay, so move on to the next question, everybody. This is just a screenshot of the video where you can see the same thing has been explained. Golden brown ring in the periphery, KF ring, Wilson's disease, and check the serum ceruloplasmin levels. Moving on to the next question. What is the most likely diagnosis in the image given below? This was probably the most difficult question as per the students because at least in ophthalmology, we don't teach it very regularly. This was something which was, ophthalmology, dermatology, a combination of that. Not a very commonly asked question. So that is why probably students who had not read this ever or who had not done their MCQs, they probably found it difficult. But still, again, even though I found it difficult, I would have adopted the rule out approach. Yes. So it was straight away image-based question, how to identify the case. Now, what is the case we see? We see some kind of growth. Let me just say what I am seeing. We see some growth around at the limbus. Yes. Okay, I know this. Now, first option, pterygium. Can it be pterygium? All of us have seen a pterygium thousands of times. If you have never seen a pterygium, let us show you a pterygium. This is what a pterygium looks like. Pterygium is a growth of the conjunctiva over the cornea in a triangular manner. Yes, it is a degenerative condition of the conjunctiva. Pterygium, all of us know, it is not even close to pterygium. Yes, all right. Now let us see what is pingecula. Pingecula is again a conjunctival condition where there is fat and lipid deposition over the temporal conjunctiva. We have read this. Again, let us see how does a pingecula look like. You could have confused a pingecula with a pterygium maybe if you have not been clear about this. But I don't think you can ever confuse it with what was given in the image. Yes. So small kind of fatty deposition over the temporal conjunctiva. That is what pingecula is. We have seen these images. Now that basically left us with two options, dermoid and dermolipoma. Yes. Dermolipoma is loosely also fat prolapse. Loosely. Though they are two different conditions, but loosely dermolipoma cases and fat prolapse cases, they present similarly. Okay, everybody? Am I making myself very clear? Dermolipoma is kind of a cystic swelling. Whereas dermoid, I hope all of us understand, this is a choriostoma. Yes? Choriostoma is basically some tissue growing at a place where it should not grow. In this image, everybody, you just see a growth at the limbus, but there are no hair follicles, etc. visible. Usually, we say in dermoid that you will see some hair follicles also. Okay? Had you seen some hair follicles, it would have been a very easy image. But because almost everybody said, sir, no, there were no hair follicles visible in that, otherwise dermoid would have been the answer. That is why probably it became difficult. So now whether it was dermoid or dermolipoma can be cleared through these two images. This image, everybody, this is dermoid. This is a growth of a tissue, whereas this, everybody, you see, this almost looks like a prolapse of a tissue. This is a case of lipodermoid or dermolipoma or fat prolapse. All these are interchangeable words. Okay. How do I remember this? Dermoid usually presents either at limbus or over cornea or over sclera near limbus. But lipodermoid or dermolipoma, this is peripheral. Okay, peripheral, somewhere here, everybody, peripheral fat prolapse is there. So you don't see anything anywhere near the limbus at all. Also, everybody, remember dermoid, very important point. When dermoids are seen in the eye, the most common quadrant is the inferotemporal quadrant. Most commonly, we see it in the inferotemporal quadrant. If we knew this, everybody, we could have seen this image, and we know it is being seen in the inferotemporal quadrant, and it is a growth at the limbus, and that is why it is a case of dermoid, without any doubt, everybody. Okay, so there are 4 options, out of which 2 would have been easily ruled out. As I always say to all my students, MCQ solving is an art. The art is at least making your odds 1 out of 2 instead of 1 out of 4. If you can do that, you will be successful. You can think and solve these questions. That's question number 4, everybody. Now we move on to the next question. So moving on to question number 5, guys. Let's read the question. A 60-year-old female complains of blurring of vision, obviously, and gives history of diabetes, obviously, for the past 10 years. On examination, findings as shown in image were seen. So basically, it's an image-based question. Yes. What is the most likely diagnosis and treatment? All right. So they have just given you an old age patient having diabetes. So basically, you have 2 clues here to find out the disease or the diagnosis. But more than that, let us straight away see the image. What do we see in the image? We see that the pupil is dilated. Yes or no? All of us can see that in this image, the pupil is dilated. If the pupil is dilated, they are basically trying to show us the lens. In the lens, they must be trying to show us what, everybody? Cataract. Okay? Without seeing the options, this much I know. Now, let's see the options. Are all the options cataract? Yes. Sunflower cataract, rosette cataract, immature cataract, and zonular cataract. Now, which cataract is this? That's the question. So, it is basically an image-based question on identifying the type of cataract. So, does it look like a sunflower cataract? Maybe, I don't know. Rosette cataract, immature. and zonular. Out of all the four, if I had to say what I would have said, yes, you are saying, maybe you are saying correct, but I'll show you the images and let's revise with you all the four images and then I'll answer this question. So let us see the first image here. What is this cataract? This is a star-shaped cataract. As I've already said, this is what a rosette-shaped cataract looks like. I'll just rub out the edges for you. Yes, so this is a rosette-shaped cataract. Now the second, everybody, this is the famous photograph. I know all of you know this. This is what a sunflower cataract looks like. Then the third image, everybody. What do we see in this? We see a central cataract with some small, I'm just marking them, some small spikes all around. Yes. So that means this is a zonular or a lamellar cataract. Yes or no? Cataract in the fetal nucleus with spikes known as riders. Congenital cataract, yes or no? Most common primary congenital cataract presents less than 1 year of age. Now if you see, everybody, the options have been put very carefully. In the image given to us, what is given to us? Small wedge shapes in the periphery. Yes. So all these cataracts that are given in the option somewhere have these wedges, whether we are talking about rosette shaped cataract, whether we are talking about lamellar cataract, or whether we are talking about our sunflower cataract. Everybody, yes or no? Yes. All these cataracts somewhere have the same kind of shape. So it is very easy to get confused in this. This was a very smartly formed question as far as the options were concerned. I am very happy at the level of the options which are formed. But the answer is, it is a cuneiform cataract at last. Yes or no? Cuneiform cataract, a stage of cortical cataract. Cuneiform cataract, incipient cataract, or an immature stage of cortical cataract. So the answer is immature cataract. And in immature cataract, what is the surgery done? Phacoemulsification with IOL implantation. So without any doubt, we are pretty clear that this is the answer to the question. Yes. Now, if we are confused further, if we want to revise, rosette-shaped cataract is seen in cases of what, everybody? I hope all of us remember it. If not, that I am writing it. It is seen in cases of blunt trauma. Sunflower cataract, famous cataract, is seen in cases of Wilson's disease, and zonular or lamellar cataract, as I have already said, this is the most common primary congenital cataract. Okay, everybody, I hope there is no confusion in this question. Straight image-based questions, straight from our video and the notes. So this is the video or the note in which we had shown you two images, both the images, one of very early cuneiform cataract and one of late cuneiform cataract were given, and that is what the answer was. Am I pretty clear about this? Yes. Moving on to the next question. Again, a question which students are divided on. I will show you both versions of it. First of all, the version which I think was actually asked. A patient has bilateral right-sided loss of vision. Again, this question is all about English. As I maintain throughout my classes, MBBS is more than anything an understanding of English, because that is the medium of our study and that is the medium of examination. So what is the question asking you? The question is saying a patient has bilateral right-sided loss of vision. Now, as I always say, visual field defects, always draw the visual field. Divide it into two parts, temporal, nasal, nasal, temporal. But that is where the problem of the students is, sir, there was no temporal, no nasal. If there was none, then let us remember what is the other way. This is the left side of the left visual field, right side of the left visual field, left side of the right visual field, right side of the right visual field. So what is the patient basically trying to tell us? That in both the eyes, I have right-sided loss of vision. Okay, are we pretty clear? That makes this a case of right-sided homonymous hemianopia. Okay, right-sided homonymous hemianopia. If it is a right-sided homonymous hemianopia, We know that homonymous hemianopias are contralateral. If it is a right-sided homonymous, then the lesion has to be on the left side. Below optic chiasma, all lesions lead to homonymous hemianopia. That means optic tract, lateral geniculate body, optic radiation. We are looking at the contralateral side, so we are looking at which side? Left side, and that is our answer. Now we need to find left. There is only one option left, optic tract, as simple as that. I hope we are pretty clear about this, everybody. Yes, option D, as far as the students have told us, it was only optic radiation. Had it been left optic radiation, I don't know how you could have answered this question. It must have been either only optic radiation or right optic radiation. I doubt that there will be two options, left optic tract and left optic radiations. I am not sure. As I said, this is a recall session. This is what I've got to know through my students. If anybody of you has any input, please feel free to answer. Now there was a set of students, a very small set though, which said, sir, this is not the question. The question had said that there is a bitemporal loss of vision. So if the question had said bitemporal loss of vision, then I think this was the easiest question overall in your whole paper. Bitemporal hemianopia is due to lesions of optic chiasma. I think this every student knows. So I personally don't think this was the question. This is a very small percentage of students who have given me this question. If this was the question, then the answer was pretty clear. But the option, the answer, the question was most probably what is on your screen. And this has been taught to you very clearly in your classes also. The right-sided homonymous hemianopia, all the fibers and every way we have spent a lot of time explaining you the visual field effects. I hope this was an easy question for all of you, and that is what the feedback I have got also, right? Now, question number 7, guys. A 70-year-old patient presents with distant visual acuity of 6/18. That means basically there is some loss of vision. Okay? For distance. Obviously 6/18 is for distance. Let's start, yes. Which improved on pinhole testing. Okay. He gives history of not needing glasses for near vision now. Okay. So that means his near vision has improved. His near vision has improved. That means he already had presbyopia greater than 40, but now his near vision has improved. As soon as I read this, my mind straight away goes to something I had read in my notes. What was that, everybody? That was something known as second sight phenomena. See, it is very important. All the points in the question are straight away giving you the diagnosis. Yes. On ocular examination, findings as shown in the image were seen. Okay. Patient has which of the following refractory error? Very good question, right? Direct question, but very good question. Let us see, everybody. First of all, we know this much. Second sight phenomena, as soon as you know second sight phenomena is seen in which cataract? Nuclear cataract. In nuclear cataract, there is loss of vision for far. Yes, obviously there is loss of vision for far. Yes. Now let us see the image. Let us confirm if what we are thinking is right. This is an oblique slit lamp image. Again, this has been pretty well explained to all of us. If not, then let's understand here. Light is being thrown from this side. This is first of all the slit which shows my cornea. Then this black area, this shows my anterior chamber. Then this is my lens. This is the anterior structure or the anterior capsule of lens. This is the cortex, and then this, everybody, this dark yellow, this is my nucleus. Yes or no? What is the color of nuclear cataract? The color of nuclear cataract is yellowish. First it is yellow, then it is orange, amber, and brown and black. Yes, due to deposition of a pigment called as urochrome. So we see on an oblique slit that the whole nucleus has become yellow. We know the patient has second sight based on the history given in the question. So we know for sure that the diagnosis we are talking about is nuclear cataract. So now the question becomes as simple as nuclear cataract leads to which type of refractory error? And I hope all of us know that the answer is index myopia. Yes? If not, then let us see. This is a straight image from the video, everybody, a screenshot. Why does it occur, everybody? Normally, when the light is traveling from air with a refractive index of lens with a refractive index of 1 into the lens with a refractive index of 1.40, the image is formed at the retina. But in nuclear cataract, there is increase of refractive index. So when the refractive index is increased, let's say now to 1.50, so now the light is traveling from a rarer medium to a much more denser medium. So now the light refracts at point B. Point B means in front of the retina. In front of the retina means myopia. Why is this myopia there? Because there is increase of refractive index. Okay, everybody. Why is there increase of refractive index in nuclear cataract? Due to sclerosis. What is the pathology? I hope you know. Sclerosis leads to increased refractive index, which leads to index myopia. I hope I'm pretty clear about this. Yes, this was the image which was explained in the videos also. So these are direct screenshots. I hope you remember them. Now, if you had applied yourself in optics, you also know the causes of other conditions. Axial myopia usually occurs in cases of boophthalmos. As we had discussed in question number 1, boophthalmos, enlarged eye axial length is increased, leads to axial myopia. Curvatural myopia is seen in keratoconus. In cases of keratoconus, cone-shaped cornea, the curvature is increased, power is increased. Positional myopia, very commonly seen in Weil-Marchesani syndrome. I hope you remember. Weil-Marchesani syndrome leads to what, everybody? Weil-Marchesani syndrome leads to. Yes, ectopia lentis, march forward. Yes or no? So because there is anterior dislocation of lens, it leads to positional myopia. So all these causes have already been told to you, discussed with you, explained to you in detail. This is just a small revision. I have already said that the examiners are going to ask you applied sciences. These are applied sciences. They are no more going to ask you straight questions. What is the color of nuclear cataract? That is not the level of your examination now. So all this has been taught to you. You have been taught the applications also. It is just upon you to be able to revise them. Revision plus hard work is equal to success. Continuous efforts are needed for success, and that's all. Yes. Now, moving on, everybody, to the 8th question, to the last question which was asked from ophthalmology. Let us see. It was an image-based question, but not what you would expect from this image. Yes. What is the dye and the filter used as seen in the image? Again, a direct question, everybody, if you have attended the classes, if you have read the notes, everybody. Yes. What is the dye and filter used in this image? First of all, as soon as I see this image, I know we are talking about dendritic ulcer. Dendritic ulcer means herpes simplex virus. All that we know, but they didn't ask you that. They've asked you the staining, this green color you are seeing because of what, everybody? So, two options were given, whether it is fluorescent dye or lissamine dye. If you remember, there are 3 dyes which we use to stain the cornea. Let us see, let us quickly revise. Let us see the first image, everybody. This is a pink colored dye which we see, everybody. This is which dye, everybody? Yes, I know, rose Bengal dye. Rose Bengal dye is used to stain necrotic tissue, everybody. Yes, it stains necrotic tissue. Okay. Now, the second image which we see on the screen, image B, in which we see a greenish, cyanish, bluish kind of, or either I can say actually teal color. That's the new name, everybody. Yes. So this teal color or this green bluish color, I can say, this is your lissamine green stain. Lissamine green dye. Lissamine green dye, when you visualize it under red free filter, and it stains mucus or mucin. Stains mucin. Okay. None of these images look like the image which has been shown to us in the question. So let us see now this image, everybody. We see a green colored dye here, everybody. Yes, a green colored dye which is fluorescing is fluorescent dye. This is a straight screenshot from the video, everybody. An orange colored strip which is used to stain the cornea. Then under cobalt blue light, it illuminates, and fluorescence staining or fluorescence occur with which color? Green color. So that's our third dye, everybody. Fluorescein dye. I hope we are clear about this. Yes. Now let us go back to the question, everybody. Yes. We see a green colored shining lesion under a blue colored light. Green colored shining by absorption of blue light. Orange colored dye, fluorescein dye. So fluorescein dye visualized under cobalt blue filter. Okay, I hope I'm pretty clear. I'll just show you the image again. Orange colored dye under cobalt blue light, fluorescizing as green. This was the pretty easy question. Now, fluorescein dye has many applications in the ophthalmology. So what are the uses of fluorescein dye? That's the next question which you can expect sooner or later. Lots of questions are asked. Let us see, everybody. First of all, it is used for diagnosis of dry eye. In dry eye, we do something called as tear film breakup time. You stain the cornea, you illuminate under cobalt blue light, all the cornea is fluorescing with green color. Then you wait for the tear film to break. Okay, as soon as it will break, there will be a break in the green color, there will be a dark spot, and that is how you will know tear film breakup time, and that is how you will be able to diagnose dry eye. Then identifying and monitoring corneal epithelial defects, corneal ulcers, corneal abrasions that we have just seen, like in case of dendritic ulcer. Applanation tonometry, I hope all of us know. In applanation tonometry, we see Myers. Those Myers are also formed under staining by fluorescein dye. Performing Siddle's test. Yes, perforating trauma. I hope you remember, everybody. If a perforation and active lesions exist, fluorescein is diluted by the aqueous. Fluorescein will go inside and there will be some kind of fluorescence happening inside the anterior chamber also. So there will be a yellow-green stream of diluted dye within the dark orange dye. Yes. Now, nasolacrimal duct patency done through Jones dye disappearance test. This has again been ably taught in the chapter on watering or lacrimation or epiphora. FFA, fundus fluorescein angiography, all of us know, to find out conditions like cystoid macular edema, CSR and other conditions. This is given as an IV bolus, and finally it's an off-label use to stain the vitreous. These are some of the important uses of fluorescein dye. I hope you will be able to remember them. Right, guys? So this was our last question, everybody. I hope all of you have been able to answer these questions. All of you remember now how to solve the questions. The art is not to get flustered in the examination. The art is very simple. That if you don't know a question, try to rule out the options. Try to at least eliminate 2 options. Try to give yourself a chance. The competition is increasing, yes, but you are doing the hard work. You are putting in the effort. Now it is all about getting that attitude. Aptitude you have, it's about the attitude. It's about the art of loving the MCQs. MCQs are a challenge in themselves. The best of the students, if we do not develop the art of solving MCQs, we somewhere lag behind. Fall in love with MCQs, fall in love with MBBS, and you will succeed. Thank you, guys. Bye-bye.